You know him.
So, well, welcome everybody. We're very pleased today to have Dr. Jaime Miranda, who is professor and head of school at the School of Public Health, Faculty of Medicine and Health in the University of Sydney, Australia. Prior to his move to Sydney, he was a full professor in the Department of Medicine and founding director of Chronicus Center of Excellence in Chronic Diseases, both at Cayetano Heredia in Lima.
Thank you.
His work brings together epidemiological and health policy aspects of chronic non-communicable diseases in low and middle income countries with a focus on obesity, hypertension, diabetes, and mental health. Probably hits on everything people are interested in this room about. I was going through this and I thought, I am so unqualified to do this. I've got paragraphs here of all of the advisory and leadership positions he's done for World Health Organization, Pan American Health Organization, just really impressive with all of the time you've spent and given, just amazing for service. He's a fellow of the Faculty of Public Health of the Royal College of Physicians of the UK. And what I think is really impressive is that his research and academic trajectory was profiled in The Lancet and described in Nature as, quote, model of interdisciplinary research that is scarce in any part of the world, which is quite a compliment. So I'm going to turn this over to you for a wonderful presentation. And thank you for having me with my Spanish.
Thank you to Alice this morning for hosting me, my pre-meet, and for guiding me through campus. And it wasn't my intention to show off the campus of the University of Sydney, but here you are. A lot of similarities. Not only tradition, but also out of respect. The labor and the functions that we're able to do builds on years of curating and sharing knowledge traditionally cared for by the Aboriginal communities. So our appreciation, our thanks to them for allowing us and affording us to do what we enjoy the most, which is knowledge generation. Quick slide for my declaration of conflicts of interest so far. Those are guiding my career. And importantly, coming from Peru, being a South American, and having gone through the COVID pandemic, there's no presentation in my career that goes without a massive thanks to all of you guys. A lot of my research trajectory builds on this work of Chronicus, and we had to face the question of, why are we doing this? Why are we in this business? But importantly, why are we in this together? And it was through these values that we're able to sustain this career from Peru, made for Peru, and made it to international arena with generosity, innovation, integrity, and quality. And we're so busy doing the research mousetrap game that we're not realizing what was happening in the broader surface. And someone from outside had to come and look at it and say, this is what you're doing. And thanks to them for their words. A lot of that has been informed by this collective learning from various people. Everybody has something to contribute in a good way, in a meaningful way. And it's our job as leaders to make the most of this diversity, of these ways of thinking and ways of operating. And we have to be prepared to make mistakes. In this place, we are real, but also we make mistakes and we say, I'm sorry, I screwed it up, which has happened quite a few times. Digging into public health, and let me make a pause here, because I want this slide to be one of the take-home messages for you. It's one of those who guides my work. I was trained in medicine. I did epidemiology. I did it on the School of the UK. And you know, large sample sizes will guide your research question. That's the mantra. And I was sitting on the class and somebody came with this slide and said, oh, that resonates with me. And he said, look, in addition to the high-risk approach, and we've been medically trained, you want to identify who carries the bomb, right? Or is that individual case that's going to explode? But there are other angles as well. And we should criticize this graph in the sense we're comparing apples with pears. So we have a solid line, which is civil servants in the UK, in London, and a dotted line, which is Kenyan nomads. The point being of the graph is that what makes difference these two populations. We can navigate into the areas of genetics or environment or behaviors. The point being is that we have completely different distributions in a given risk factor. This is a plotting of systolic blood pressure, and you will see by most of our clinical colleagues, 140, hypertension. In the UK, half of the population pretty much in that range. In the Kenyan numbers, a tiny bit of a tail. So the answer to that question has to do with the determinants of the population mean. And I think for us working in public health and with an interest in public health, we have to come back to this, the determinants of the population mean. Because we have to aim, if possible, as much as we can, for an entire shift of the distribution. Now, a lot of my work is around sense making. Right? So what do I think about Latin America? What do you think about Latin America? And yes, we know it's one of the fastest growing areas in the planet. Latin America came to being highly rural to highly urban in only 3 to 4 decades, from the 50s to the 90s. Also, we have a rich story of colonization and independence and institutions working or not working. Let's set aside institutional failures. I know you're going through big uncertainties today here. That's our bread and butter every morning. Our presidents are in the jail. But also in larger contextual things. So some of you, and actually my colleagues from Brazil, will know this picture very well. So what determines the chances that living or being born 10 meters apart would have such a massive and dramatic impact on your life expectancy of 13 years difference. And that's the price of inequalities. The picture on the right-hand side is Lima. When you face from the hill that side, that's a beautiful picture of the Spanish capital. But when you turn 180 degrees and you look that way, that's where the millions of populations live, in a very unplanned area. So we've heard of Latin America being rapidly developed, economic growth, highly urban populations, highly unequal. But on top of that, what do I think when I hear Latin America? I want you to focus on the orange line, which starts in year 2000 and plots chronic undernutrition. And now being that we are in noon, we're going to make a pause here. I'm going to invite you all to stand up, pause your sandwiches, pause your lunches, and please stand up. We're going to see this exercise works beautifully in South America. It doesn't work in Scandinavia. I'm going to test it with you. So I want you to put your hands to the height of your mother. I want to see how tall was your mom. All right, look at that, Victor. Then I want you to push the line to your grandmother's height. Right, there you go. Have a seat. Point of that exercise is within 2 generations, in general, within 2 generations, we have transformed dramatically. And this is biologically speaking, in many countries at least, our populations are becoming taller. The shortest women on the planet are still in Guatemala. If we've grown taller, I wish all of that extra gains in height would have been filled with brains or muscles, but not necessarily. I think many other cells have taken place in those extra centimeters that we have. But the point of me is plotting this graph is if we date back this to the 70s, the line would have started around 50%. So that means that 1 in 2 people will be the survivors of chronic undernutrition. And if you survive chronic undernutrition in adulthood, that will carry on some biological penalties that were exposed to this beautiful environment that we live in now, with all the stress, with all the food, and with all these physical and working conditions, will have some replication. Now, these handicaps carry into adulthood. Yes, they do. And we're reflecting in that manuscript as to what does it mean not only seeing the rapid rise of chronic non-communicable diseases, but also where do they sit, particularly in populations with those deficits. And to me, that helps us understand why we see not only onset at early ages, but also more years of living with disease, cumulative conditions, but also early appearance of complications as well. Child survival studies have made the argument of development and why it matters for society, social capital and social gains. And this is a picture of, I label this is the price of child survival. So why we did all of this then to put these adults into today's society? Look at that picture of the brain. And that is the picture of the brain of a kid, 1 year old, with chronic undernutrition. We can go through the ethics of running those studies now. I'll invite you to check the references. So if that's what's happening with chronic undernutrition on your brains, I want you to fast track to what's happening with all the rest of the organs that we don't have pictures of. For example, the organs in charge of your cardiometabolic management, your pulmonary management, etc. Yes, there will be an element of plasticity and reversal, but some of these will be long-term handicaps. And that's the population that we're dealing with in most of our countries. Now, if we have stunted children with stunted brains, I want you to think of stunted organs. All of this is not something to begin. I said that reversals are happening and happening in a short time as well. This is from the UK, within the OECD states only, the richest countries on the planet. And you're seeing the kids in the UK are amongst the shortest of that league. So let's prepare to what comes with that when these kids become adults. So we have to do with many tools and many tools that we have at our disposal, and implementation science is becoming one of those that allow us and enable us to transition from what is known to what can be done or what should be done. There are many definitions. I shouldn't run through this room, but quickly, what works for whom and under what circumstances is something that most of us will tend to agree with. And in my mind, thank God I didn't study medical anthropology. When after leaving clinical medicine, I went to the Andes, and let me tell you the story. And I applied to a course in Europe to study medical anthropology. I got accepted. I passed my English test. I didn't have anything to study. Thank you. Because I'm a very, very, very slow reader. So in the way I learn is through images and through pictures. So implementation science in my mind is this. It's the transition from the lab, where we discover beautiful things, engines that work perfectly, that are tested in multiple conditions, velocity, weight, price, whatever, color, etc. But these engines have to go into the real world. So far, so good. Not so good. All right, bit of when my colleagues in Sydney complain about traffic, I say, hang on a second, it's only 4 cars ahead. And this is where we ought to frame or place our research questions. From discovery to implementation, what's happening there? Because things fail. And things are failing. We should be prepared. We have the tools, and actually that's our social contract to inform society on why things are failing and how we could do better. This slide is quite useful for me as well. It's a very practical exemplar of from the lab to the field. And I love the creativity of these guys from the beautiful title, from 70 to 700 to 7,000. You will see 70 beautiful effect estimates, odds ratio or effect size of 2.5. Then as the study got implemented into real life synchronicity, you went all the way to 70,000 with almost a null effect. And what happened there? The lesson from the Jamaica experiment was this psychological and I think it was cognitive support of kids in, oh my God, nursery, right? So if you look after them early, they will have better outcomes. The 70,000 was a proven experiment where they say we ought to roll this out quickly, rapidly, and we didn't see any benefit. What happened there? Is that a bad idea or was it implemented poorly? The number of trainings were not the same as the protocol originally. The staff rotation and turnover was really high. People didn't stick to the fidelity wasn't the highest, etc. But a calling reminder that from evidence to practice, we have to jump many hurdles. And then a lot of our work will have to sit in a context, and maybe for many of us, that context will be primarily a health system. And here's my little sense-making exercise. This is the health system for me. I don't have pictures, guys, of your complex and beautiful buildings and large connecting. Rachel walked me yesterday. I'm already nearly 50, and I was still amazed that you can walk across the building. Wow, there are trees inside the building. Wow. So maybe that's the health system for you. That's not the health system for me. For me, the health system is we keep adding things onto it, the things that were not designed for this purpose. And yes, we might have a little project here, and then we're going to put air conditioners there. And another project say, well, our people are so tired that they need hammocks. I love the picture of a hammock. It's in it. I'll zoom in, and there is a hammock there. But the health system failed. And health system failed abruptly, acutely, dramatically. And this happened 2 years ago. All of us were shaken, and a word of humility was brought to us through this pandemic. I wish this was a World Cup ranking. I'm going to list it, not to practice my Spanish in front of you, but you have to listen. Peru, Ecuador, Bolivia, Mexico. There you go, top 4. Colombia, Paraguay, Guatemala, Brazil. We're doing quite good, but not necessarily for the good reasons. Latin America and our health systems is telling a story that things are failing. And these are the images, and I don't need to share images with you. You all have very close images of how our health systems failed a lot or were put under severe strain. So, Latin American populations, individuals, synchronizing what's our starting point, right? Science, health system. And then what are the kind of research questions that we put forward? First one, that graph over a year's time, that's new cases of hypertension in the UK, new diagnosis, people taking medications. When I went back to Peru, I couldn't quite make sense of this. They say, free healthcare system, you have access to doctors, you get a prescription, you go to the pharmacy, it's free at the point of care, you see your doctor regularly, or used to, now things are changing, and still halfway through, people are not taking their medications. The other example to the right-hand side. So if they are not taking their medication in the UK, then how on earth I expect the people will take the medications improve? We don't have a free healthcare system, we don't have doctors, access is limited and constrained, etc. What else is going on there? The right-hand side of my screen, for those who are on the computer, is an example of just playing with this data, is the use of time service. So what does it take from going to a medical appointment for someone with diabetes to get that label of diabetes? That means you have to wake up at 4 a.m., go to the hospital, pay for a medical record, pay for an appointment, queue for their appointment, come back for the doctor's appointment when there's a slot. The doctor will send you to a lab test. You have to go to the lab test, fasting, you have to come another day. You have to come another day and pick up the result for you to take it to the doctor. When we quantified the use of time invested into seeking care for something as simple as getting a label of diabetes was 4 days of work. 4 days. So if you live in the informal economy, if you live by the day to feed your family by the day, if you live with less than $200 per month on a basic income salary, can you forego 4 days of work to go to the doctor? Not necessarily. But even despite that, So education, adherence, we have a problem. Then we have a problem with time consuming. And then we did a study, which I love to repeat one time. Despite people, all those obstacles, there are some people who are coming to the hospital. So I'm going to use Mark as an example. Mark is a cardiologist, well-trained, good-looking doctor. Everybody wants to see Mark. So we waited outside of the room. I cannot go so much. So we waited outside of Dr. Mark's consultation. Asked the people, do you believe on the prescription that you were given? No. Not only that, believing is one thing, but do you think that it will introduce some harms? It will make you bad? Yes. So, in spite of these obstacles, societal, structural, socioeconomic facilities, people don't believe on the things that we're doing. And then why adherence is a problem? And then we write beautifully, you have to eat better. You have to do more exercise. You have to do physical activity. But in Peru, food is sacred. You have the church and food table. So does it mean that you have to cook separate for someone who has hypertension or diabetes? Does it mean that this person has to eat elsewhere? Does it mean that this person cannot socialize with the other? So this study was quite telling for us. We would assume that everybody has the same appetite to look after their health, but health and caring for health is also a social contract. It's not easy to live with this illness. I don't want to be separate. I'm amazed of all of our colleagues who stick to the diet, but when it's a social thing, it's really, really hard. And I pause here because then what does it mean for the people, right? We're doing all the research questions. We have all these infrastructure and facilities, and this is my picture. What is it like? How does it feel arriving to the health system? In terms of customer services, guys, it's terrifying. We don't see it because, we're trained there, but now I'm the doctor of the family, and my family is quite large. It's just the question. It's terrifying going to see just to cross that door and what to expect. Let alone exiting health services. And the exiting is not necessarily any better. So these are my health systems pictures. So let's move, with that background, let's move on to what have we done? And this is my research slide. And trying to fulfill or complete that image of a dog. In this case, trying to fulfill the idea of the research in chronic conditions in Peru. This is mass use slide in Australia. Where is Peru? I think I'm going to take for granted you know, guys, where it is. But it's a tiny, tiny, tiny desert line, and then you hit the islands immediately. And we have people in these natural laboratory environments, people living at high altitude at sea level, people living at mega cities and small cities, people living in tropical areas and less urban areas and very urban areas. And with that, we were able to document or to clarify or to unravel the patterns of chronic conditions in these settings. The message is, whenever you see a natural aggregate in Peru, please ignore it, or please raise your question, raise your hand. Don't believe that number. It's not about Peru. Where in Peru are you talking about? We did this study as a natural experiment. We had the years of terrorism and guerrilla. A lot of people were pushed out of the rural areas, and they landed in Lima, in a very particular area in the south. This is on the south of Peru. People from the central Andes will migrate to the center of Lima, and people from the north, like me, will migrate to the north parts of Lima. So Lima is a mix of 15 million people we're mixed from everybody. I'm proud of this slide because it doesn't show any statistical analysis on there. I want you just to focus on the very first line. Top line, 77% of people in rural areas do not have any of the 5 major risk factors. So we keep studying those with problems, but we don't study with things that are good that we should promote and things that are doable, feasible. What is happening is people maintain the standards that we always strive for. It's a combination of five major risk factors: smoking, high blood pressure, high cholesterol, high glucose, and physical activity. 77%. Yet, when we look at this population over time, the fact that you're exposed to different environments, but also the fact that you have different cumulative exposures, means that the incidence is very different. We will easily label as these people, all these migrants will develop chronic diseases. Actually, yes, the incidence is higher for obesity among the migrant group. The incidence of hypertension, and now Victor is doing a lot of phenomenal work in rural areas, is a problem in rural areas. It's rising more than in urban areas, more than the migrant. And the incidence of diabetes is much higher among migrants. Quite interesting. Population, the same country, the same cities, with different profiles. With that, we move on to, if that is happening with one particular transition, one change of environment from one area in the Andes into the capital, what's happening with the rest of the country? So we expanded to, as I said, we expanded to Puno, 4,000 above sea level. And Puno is a border with Bolivia, and you have a lot of tourism, not tourism, but a lot of commerce. It's a trade border. You have a very urban area, and also minutes within that, you have very, very, very rural areas. And then Tumbes, the border with Ecuador. And the message of this slide is, if I were to be the Minister of Health in Peru, I will be challenged whenever an issue a national policy, because the coexistence and the occurrence of diseases, including mental health, is very different. So, building on that experience of every time where there was this national pool, I say, hold on a second, yes. But let's not forget about the patterns of disease of Andean populations. So here we're in this regional effort trying to put inform risk prediction is called. It's quite a common tool in the cardiovascular field. Would that be something specific for Andean populations or South American populations? Some of our other adventures of data pooling took us to this publication in Nature, which is quite interesting. Like, yes, we tend to see and describe of the rise of obesity and maybe assume that it's an urban-driven phenomenon. Actually, it's not. Most of the magnitude of growth in the prevalence of obesity comes from changes in rural areas. And we had the quite a benefit and the opportunity of zooming of Latin America using that extensive data set to understand what were the challenges. And we know, okay, diabetes is a big problem, particularly in the Caribbean islands, and hypertension is a problem in many other countries. I like this study because we still have a window of opportunity. Obesity, as many other conditions, has a social gradient. The moment that obesity sits on the richer stratum of the population, the moment that the obesity shifts from the richer to the poorest, we have an exponential problem. Because to move or to change 1 point prevalence on the group with high income is very different than to move or change 1 point prevalence in the poorest groups. Agencies differences, resources are different, the cumulative problems are different. So by mapping this, we say where we are in Latin America in terms of socioeconomic indicators and obesity. And some countries still have that window of opportunity. I like this study, and big shout out to my friend Ellis here. I invite you to connect with him. My first visit to San Luis was on this project, Salud Rural, Urban Health in Latin America. You know, story, rapid expansion, quick growth. How do we inform the literature in urban health? And most of that literature is predominantly English speaking. Access to green areas, good for your health. And hang on a second, you get killed. You don't go to green areas. You don't go to that thing called leisure sport. Doesn't happen, right? So we publish this in a way. I mean, the effect sizes are not that big, but we're controlling the direction of the effects. We're not necessarily on the direction of the literature. urban sprawl, it's good for health. The way that cities grow in an organized way will bring benefit. Our cities in Latin America don't grow in an organized way. And actually that introduces further challenges. So I'm not only there, my job there is to bring a voice of Latin America, to bring a voice of research to say, hang on a second, is this happening in a similar way, in a similar fashion, with a similar pattern or not? And yet we have to move to experiments. And this picture is to say, how do we entertain our ideas across multiple settings? We did this study before the pandemic, testing with the option of, can we use other health professionals to introduce behavioral changes rather than having a doctor to give you a label of, say, you have a problem, then you have to start diet or changes in physical activity. And we show reductions in weight, 4 kilos, by having a nurse calling you on a phone and guiding you on your food options and choices. And those reductions were sustained after 5 years. So I invite you to read that paper. This study was a negative study, but I'm proud of this. It's a negative study because we have a problem of diabetic foot ulcers, right? The moment you have diabetes, and if it's uncontrolled for so many years, the chances of developing neuropathy are quite high. And having neuropathy means that you don't feel. If you don't feel, you don't know what's going on. There was this tool called thermometry. Before an inflammation, before an ulcer's onset, you will have inflammation, but you don't feel it. So the uptake of this thermometry in the US was 30%. And we said, we're going to do a study to improve that. We're going to lift it up to 50%. When we arrived with the technology, we found that it wasn't ethical not to give the thermometry, so we gave the thermometry to everybody. And on top of that was our question, our randomized control trial question. The uptake of the thermometry was 85% in both groups. People were desperate to have something. There's nothing out there. Desperate to have something. And then moving outside of these clinical spaces and clinical encounters, we designed this study of entirely shifting the supply of salt. And we know that one of the problems with hypertension is sodium. Sodium comes in the salt. Many of the salt utilization comes with the discretionary use, at food for cooking. And you can replace that part, a proportion of that sodium, by potassium. And you have the dual benefits. So you reduce the sodium, but also the increase in potassium has beneficial effects in reducing and lowering blood pressure. Dual benefit. How do we do this? Those of you who were in the study, who were in my presentation yesterday, this is where I lost money. We did a call for proposals, and we said, help us design the intervention, the social component of the intervention. And 2 anthropologists came, and they came back. Oh, you have to say, Jaime, you have to say, you have to eat less salt. And I say, I'm not paying you hundreds or thousands of dollars to repeat what the doctor is saying at the office. So we ended up hiring a social marketing team. They didn't come from the health angle. They have another thing. And their job was to replace and to compete on the market standards with one product was there, regular salt. And they generate a different strategy of the arrival of a new product that wouldn't alter taste, and maybe it will have some benefits. So the health benefits were not minimized, but were not the center of the campaign. And we show reductions at the population level. Remember the first slides of the shifts of the curves? So we had to demonstrate that entire shift of the distribution. And also it had all their additional benefits, such as the appearance of new cases of hypertension were around 50% less. Less cost, less need for consultations, less need for appointments, etc. So these things of thinking at population level also have dramatic impact. And then, because I am the focused one, I couldn't have made a career of doing one thing. I moved to work with a psychiatrist and say, guys, I know you keep talking about depression, but can we bring your discourse closer to the cardiologist? No, they won't listen. Leave that with me. And the joke of this study is, do we need to train somebody with 7 years, 4 years, 5 years of specialization, try to retain it, not to go to the private sector and stay in the public sector, to start a conversation with, hello, how are you? Tell me of any business where will you invest 14 years, pay a lot of money, to have someone to go to you and say, hello, how are you? The doctors are very busy, psychiatrists are, and yeah. And all I asked was permission to say, hello, how are you? The cardiologist say, off you go. And who was going to say that? So the study was designed so that there will be a human component, a nurse in a company. The job of the nurse was not to give you information. The job of the nurse was to say, hey, by the way, Anuba, you were meant to log in. What happened? Oh, my battery, I lost my battery. Or my cable didn't connect. So, I mean, troubleshooting the engagement with intervention. 6 weeks, 3 sessions per week, very light intensive. For those severe cases, yeah, we're connected to the health system, psychiatrists and so on, very rigid mental health protocols. But those on the large masses, mild to moderate depressive symptoms, we could offer something. I don't have the results here. You can look it up. Beautiful work in Peru, laboratory conditions. We hired nurses that were doing the job. That was their only job, to follow up to this protocol. And a 50% reduction on the effect size in Brazil. That's the reality of implementing within the existing operating teams. So we have 2 trials, an efficacy and effectiveness study within the same protocol. So I invite you to read that one. And then not going any further, this was made by the foundation of my trainee. You see the signal there, fruit. We asked the food vendors, why is the fruit over there? Oh, because of the flies. Okay. I cannot take care of the flies, but can you live with a little bit of flies for 2 weeks and we'll pay for the fruit? All right, okay. So every day we'll come back. This was one of my students. Every day they will come back with a stop in the market, buy some fruits, arrive to the canteen, put the fruits there. You see the solid lines on top is the number of menus or food items that were sold. Okay, not major differences. And on the bottom line, you see the bars. Those are the number of fruits that got sold when we transitioned from where the fruits were protected away from the flies. We brought it to a point of purchase, and then we paused away a little bit, and then we reduced the price. Thank God there are women in this planet. All those bars are from young females. Boys, oh my God, don't know what to do with boys. And as if we were too lazy, okay, what else? What else? So let's go to churches. The Spanish did a fantastic job. 95% of the population is somewhat Catholic. Everybody has been baptized. When I was a student, when I was a kid, the requirement to enter into school was to show your baptism certificate. You see, that's an implementation, a strategy at the scale with a lot of penetration and reach. Whether fidelity, I don't know. As per protocol, I don't know. Okay, so we're having 2 students, and they say, okay, the vice chancellor of one of these was a priest, and say, would you like to work in research? Okay. And the intervention was a 20-second intervention. Your body is a temple, look after it. That's a randomized trial, the priest delivering the intervention, and we show changes immediate changes in preferences in terms of food drinks. Nobody was told that this is a so sugary drink, this is water is better for you. It's just your body is a temple, please look after it. Then I wanted to do the study with more dose. So can the priest repeat it for 6 times? And then can a doctor come to the priest's altar and do this? And I got rejected by the ethics committee. And I have this on my wall of fame. The contribution to science and society is not clear. Oh dear. See, the penetration of the church is quite high. So I got rejected twice. And I kind of elaborated with all my city. I couldn't pass through the ethics committee. There you go. If there's any other country where you can pass, please let me know. I'll be willing to repeat that study. And now my point of showing this is we have to maintain that versatility of interacting with a variety of actors. And then we went to the baker and say, guys, what's going on? Why do you use that amount of salt in your bread? And you say, and this, my friend over there, he won't start. Over there, look at that, the guy with the technology. We use that amount of salt because we have a sticker there that says that's the amount of salt we have to use. Really? Can we go and change the amount of salt? Yes, you can. But what do you care the most? Oh, we care that sales don't change. We care that flavor doesn't change. We care that customers don't notice, and we care that the consistency or the fluffiness doesn't go flat. But we have to patiently wait to measure sales for a year to prove to them that, guys, by doing a bread that contains less salt, your business doesn't change. Here's your beautiful study. The municipality say we want it, but Facebook came to the game. And this became the prime picture for the Saturday market. And we said, no, please do it throughout all the bakers. No. On Saturday, we need to show that we're doing something for the benefit of the community. So this was the healthy bread that the municipality was proud of. That was my failure. Okay. Then, versatility, navigation, but then the reality that conducting research will face us or will be encountered with these propositions or circumstances where things are changing and changing rapidly. And we're seeing a lot of co-production or co-design now being not only a much needed, but actually, how do we evolve in this? It takes more time, it costs more money, but oh boy, so enjoyable. I wouldn't claim that all my research projects will follow this path, but if I have the time, the energy, I will go for this. Thank God that some of the funders are essential for them. So NIHR say, you cannot execute one of our pounds if you don't have this well. In an invitation for us to feel uncomfortable, to invest time in a meaningful way, in a horizontal way, and in a respectful way with our communities. So we did this study with engagement in Nepal, Mozambique, and Peru, rural areas, rural settings, and we have tended to understand the health system from deficits, particularly on the supply side. Oh, there's no doctors, there's no nurses, there's no healthcare professionals, there's no tests, there's no drugs, there are no protocols, there are no infrastructure. The community says, hang on a second, you keep doing all of that, but when the doctor comes, he never, ever introduces himself. We don't know his name. We know he's going to go in 3 to 6 months, maximum 6 months. We don't know who he is. And the doctor comes from the city, and he opens the clinic 9 to 4. And we have to work the land. We ask him to open, say, 4 to 6, 3 to 7 in the evening. No, can't do that. So I call this project the divorce project. We have a system, we put a lot of energy and resources into the supply. There's a divorce between the system and the community. What are the solutions? What do the community want and ask? We want the doctor to introduce himself. We want the doctor to utilize the radio. We want the doctor to announce the opening hours of the clinic through the radio. We want the doctors to recognize the role of the community health workers in front of the community. We want the doctors to visualize, to make visible all the efforts that we're making and putting into engaging with our health. We have to shift. Ignore the supply, not that kind of. Let's rethink, let's co-produce what it means to be in present, to engage, and to, I wouldn't say fix this relationship, but this is called the divorce project in my mind. And more recently, this is a new addition to my set of slides. a lot of you guys flies all the time. And you may have heard of these expectations that we have on airline companies today, that the footprint, the environmental footprint that air companies have on the environment should decrease, if not should be zero. It's a sensible ask. Makes sense. These industries have to be sustainable. These industries need not to contribute to the further damages. What would be the equivalent of having a health system whose footprint is zero on the individuals? Because we as doctors, as providers, we say we're very good at telling the other what to do. We're very good at telling and giving you a lot of tasks. Oh, come back for that assessment, make an appointment, go to the referral, make some tests, come back to them. All of that is work. All of that is workload. That if I am a doctor, if I have resources, if I have connections, I can absorb all of those. If you don't know how to navigate a health system, go back to my picture of a health system, traffic lights. If you don't know how to navigate that, if you don't have social capital, if you're not educated, if you're financially unstable, how are you going to absorb all of that? So we feel that we're doing our job by tasking others to do work. That's called burden of treatment. And now there are tools where we can capture, where we can measure at that. It's a very nascent field, less than 10 years, and it's an invitation to all of you to measure the clinical or the workload of our clinical task on the individuals. Some people are proposing that maybe there's something that can change after our interventions. You're starting with this point, the burden of treatment, it can be reduced by something good that we're doing. So that's the current work that I'm involved with. Now my journey started with the journals. I'm going to fight. What's this? Okay, etc. So as you can see, navigated from clinical medicine to the Andes, going to Europe, going back to Peru, epidemiology, large sample size, very robust methods, trials, getting published, moving on to health system, what's taking my attention now? Because as I said earlier, I couldn't make a career just doing one thing. I get too bored. Maybe I have ADHD. That project of the divorce is called this. It's this one, Cohesion. Community health system innovation. And the other one that is taking all my energy is caregivers and dementia. We focus on again on the supply side. Let's train more doctors, more drugs, but living with dementia is a 24/7 business where people don't know what to do, people don't know what the reactions are there. And in settings like ours, that care would not be taken by institutions. It will be taken by the family, or if not, people will be abandoned. So we need to step in and to rethink what is our role of health system, because the health system is not only healthcare delivery. What is our role of health systems into looking after these people, the populations, and the caregivers? Now, I'm talking for too much. I think I'm going to pause here, but that's a very lasting pause. It's a lie. And we'll just offer you 4 more slides, if you bear with me, please. Now I need to show you a picture of Sydney. This is called Public Health in Sydney. And all of this slide has been taken away in a few weeks, and you're living through this, guys, and we are living as a planet. Last year or 2 years ago, it was a high momentum to get all the planet, all the countries together towards reunite efforts towards the Sustainable Development Goals. I don't think there's appetite now to get together in that front. But a bit of a hookup, have a look at this report, Global Sustainable Development Report, 4 years into the SDGs, starting in 2015, halfway through the 2030 agenda, independent monitoring evaluations every 4 years. I was part of this team of the 2023. I was tasked and glad able to chair this team. Halfway through, story is not good, but how do we communicate this with policymakers? How can we reunite people together? And it's an invitation to think about this message. Transformations are possible and inevitable. And that's the transformation that you're living here with the institutions in the UK. Frameworks for shaping the future, think about synergies and trade-offs. Whatever you do, please move away from, oh, my work is important for SDG 3. No, that's always cool. Fail. No, you have to think outside of the box. My work is important for nutrition, hunger. No. My work is important for inequity. No. So if you ever repeat again in one of your writings that your work is important for SDG 3, 2, and 10, you are a failed student. You have to think beyond your remit, beyond your comfort zone, and think about the connections of your work across multiple SDGs. Think about interlinkages. I'm going to pass through, I'm not going to throw the report, but transformations are inevitable. This is the use of electric cars. And here's the other exercise, because you're getting 1 p.m. Stand up again. And I bet there's a 100% success rate. Put your hands in the phone. Ah, I gave it away. Put your hands in your pocket. Take out your phones. I want to see your phones. I won't steal it, don't worry. Very high. Yeah, because all the room needs to see. I want to see those of you who are still paying for a landline. Oh my. Right, okay, you have to talk to each other. Why? How was it? So with these two exercises, that transformations are inevitable, but we can shape them. There you go. You are going to be best friends now. You know, oh, hello. Can I have your number, please? This is electric cars uptake, and it will change rapidly and dramatically. So it's an invitation for people to jump on this discourse, to understand and to plan ahead, and to critically think about the opportunities that this uncertainty and these changing environments afford us to introduce transformation. I'm going to stop there. Thank you very much for having me. Such a pleasure to be at WashU. Thank you.
One or two questions? There you go.
Jaime, thank you so much. As Brazilian Latin American, I just want to say thank you for all you have done for the region. The breadth of your work and your impact is really important for the whole globe, but as part of as hermano latino-americano, eu quero dizer que sou muito grato por você.
Muchas gracias. Thank you.
So my question is.
No, shit. Sorry.
My question is now you're working in an Anglo-Saxon Australasian environment, and have done a lot of work in Latin America. So what are the similarities you see across the different approaches you have used and interventions that are transferable to different governance systems, different cultural values and everything?
That's a very interesting question. Thank you, Rodrigo, because I'm seeing how things operate with stable contexts. I was telling yesterday, the likelihood of your policymaker taking the kids to the same school are quite high. In our countries, the chances of you interacting or knowing a policymaker are high. Even so, the chances of knowing a long-standing policymaker is rare to us. The label or the title of policymaker, at least in Peru, maybe in Brazil, you have a little bit of difference. When my colleagues enter into these roles, say, congratulations, you have been diagnosed with cancer. I'm going to wait for you on the exit door. I won't see it because you have a long-lasting life of 6 months at the best. If everything goes well, a year. So now what I'm coming with is open eyes to see all the things that you can do on stable institutions. Unfortunately, Australia has many opportunities, but it's still a small country and many legacies, in particular Aboriginal communities. So I'd say those are one of the largest divides, the inequities with Aboriginal populations. And thank God it's a priority for the government, to trying to support that. The stability of Ministry of Health agencies and operating environment is a plus, but also the willingness of these people to connect. So my invitation here is reach out. I feel that arriving to Sydney, I've been given access to this buffet that is large, but it sits over there that not that many people know that can tap into. Mark is one of those cleverest ones that connects very well, but willingness, appetite, and talent is quite present. So it's an invitation to reach out. Thank you, Rodrigo.
Hi, thank you so much for that talk. That was so interesting. I'll ask just one question. There was one of your studies early on about the health system where people were very distrustful of the advice they were given by their doctors. In another study, they wanted the intervention so much that even the control group opted it. What was the difference there? And was there same concern with public health messaging and trust, or is it specific to those contexts?
Good question, very good question. On the first one, I think there's an element of saturation. So these were cardiology clinics, and maybe these people have already encountered multiple obstacles. The other study was diabetic food clinics with not that many services. So the settings were very, very different, I suppose. The other one was a pharmacological intervention. I think we're not doing our due diligence of checking in, is that what people want or not, or how to frame what. Whereas in the other one, the intervention was a film only that will put it on your bed and people will stand on it every day. So the behavior to change was to get your socks out of just checking. So people will stand there, and if you see differences, let us know. Simplicity is to use. You don't need to connect with anybody. I suppose the architecture of the interventions were very different. The delivery of the intervention were very different as well.
Thank you so much. Really appreciate the talk. That was wonderful.